Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs. Thank you. Hello, everyone, and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and I thank you for tuning in for this podcast episode titled Understanding Pain. We are very fortunate today to have Dr. Deborah Barbiere with us.
Thank you so much for having me. Very happy to be here.
So for those who don't know Dr. Barbiere holds a doctorate in clinical psychology with a specialty in health and pain psychology. She has maintained a private practice in New York City for over 30 years. Additionally, she completed a degree in Oriental medicine, incorporating Eastern modalities such as acupuncture and herbal medicine into her work. Dr. Barbiere has trained and worked in various capacities in major New York City hospitals, including NYU Lutheran Labor and Delivery, Ortho Neuro Rehabilitation Departments, St. Vincent's Cancer Care Center, NYU Initiative for Women with Disabilities, as well as Interfaith Medical Center, HIV/AIDS Center. She is currently affiliated with Manhattan Pain Medicine. So Dr. Barbiere, thank you so much again for joining me. I know that we are going to be covering a lot of information. And as you said just before, we're just going to be scratching the surface on this topic, but it is important. And I know we're going to cover some helpful information for those people who are experiencing persistent and chronic pain. At Inspira in Brooklyn, we just had 2 weeks ago a pain science event where we covered some of what we're going to touch on today in regards to pain science. What we covered was, from my perspective as a physical therapist, I'm a doctor of physical therapy, how physical therapists understand pain and how many practitioners who are dealing with pain and treating individuals who have persistent chronic pain understand, conceptualize, educate their patients, and then treat their patients accordingly. And that is the biopsychosocial model. I am a physical therapist. We reference Lorimer Moseley and David Butler tremendously, specifically their Explain Pain book. And this biopsychosocial model, as the name implies, it covers biological, psychological, and sociological impacts of what creates a painful experience. Pain is actually a danger message and not a pain message. I wanted to have you, Dr. Barbiere, talk to us about your approach to working with individuals who are experiencing chronic and persistent pain. How is that similar, or how is it different from traditional psychological methodologies?
I just want to say congratulations on a great pain event and getting the word out about chronic pain. This is so important. You're really a pioneer in making this happen. Thank you. And Moseley and Butler are wonderful in helping to make pain science accessible and understandable. And it's such a great read for patients. I also highly recommend it. To address your question about how I work with chronic pain, let me first say what pain psychology is not. In no way do we imply that pain is all in your head. It's very real and exactly as you describe it. That is always our starting point. What is pain psychology? I'm obviously a big advocate of all good therapy, but if you're dealing with chronic and persistent pain conditions, it's a must that patient and therapist understand the science, as you've indicated, right? As well as the psychosocial repercussions, and intervene through this lens. Otherwise, all the ways the brain and the body, and I'll say life, have organized around the pain will persist, and so will pain. So even if you treat it at the physical level with surgery or medication, the brain still needs to learn to heal, or it can continue to act as though it's in pain, right? We see this, for instance, in phantom limb syndrome, we sometimes talk about. And then let's add the stress of having to learn how to be in the world again post-recovery. Like a patient recently said to me, I don't know how to not be sick. Chronic pain took the me out of the equation. This can be daunting, right? One becomes estranged from themselves and their identity. Generally, when I'm working with chronic pain, I'm using mind-body modalities that affect change in the brain and central nervous system in a very specific, targeted way. I'm addressing the ways chronic pain has altered the body, the brain, the mood, identity, relationships, and so on. It is highly specialized. It's not uncommon for patients to come in already having a long-standing relationship with a therapist, and I've had a lot of success working collaboratively with other therapists without being redundant in the process. I'm also especially focused on fear and avoidance patterns, pain pathways, as we know, right? You've indicated pain pathways are really danger pathways that have gone haywire, and so you'll hear two words from me over and over again today: fear and safety. In my work, I'll also loosely call it top-down, bottom-up modalities. I'm using both. And what do I mean by this? This is important. The sensory spinal cord brain circuitry contains two-way traffic involving ascending and descending pathways, transmitting signals from the body to the brain, where it's interpreted and then sent back from the brain to the body to inform action. This is a survival mechanism. It protects us from harm. Do we move toward or away from the stimulus, like learning how to not touch a hot stove, right? Much of traditional therapy, as we know it, is top down. We talk about, analyze, process issues, and this is a very critical part of pain psychology, encompassing methods that help change the way we relate to pain, identifying core beliefs and feelings that influence pain experience. It turns out what we think, feel, and how we organize around the pain affects pain volume. So top down, we're working on changing the mind to change the body, asking the mind to let the body know it's safe. On the other hand, bottom up treatments involve neuroregulation skills like somatic body awareness, breathing, mindfulness, visualization, meditation, muscle relaxation. And here we're acting on the level of the body and the nervous system to signal safety in the brain. Some other techniques, which I may get to touch on later, are I use acupuncture psychotherapeutically. I use program called Safe and Sound Protocol, tapping, biofeedback, and various other somatosensory therapies. And here we're working on the level of the body to change the mind, calling on the body to signal safety in the brain. All of this can be very challenging since enduring pain makes the relationship to the body very complicated. Mostly we're compelled to escape or even dissociate from the body. So making these connections is especially critical in treatment, opening these lines of communication. When we ask patients to touch into the body, it's a very scary place, right? And it takes a lot of TLC to feel safe there. So it takes some time, some degree of being able to relate to the pain rather than from the pain. And we can talk about this more later.
As mentioned, the painful experience is influenced by biological, psychological, sociological components. And so as a physical therapist, when patients come in and they have had chronic pain or persistent pain, as a physical therapist, I have some skills to help if their central nervous system, specifically if the sympathetic nervous system is in overdrive, to use craniosacral therapy of visceral manipulation or vagus nerve manual therapy, and then anything biologically that might be impacting the pain, but the painful experience. But if there are underlying thought patterns, fear avoidance behaviors that you mentioned, if there are just increased anxiety and stress prolonged from the experience, pain psychologists like you to help, and for you to be a part of our team in helping individuals who have persistent pain. For myself, because we also see pelvic floor physical therapy patients in our office, when I was attending last year the IPPS, International Pelvic Pain Society Conference, they spoke and presented on a central sensitization inventory outcome measure. We have used this sometimes with our patients as a tool to identify and have some data that shows that there is likely central sensitization, and then to use that as a referral to a provider like yourself. What they spoke on to us, and maybe you can enlighten us on this, is cognitive behavioral therapy, and then also acceptance commitment therapy. I am a physical therapist, so I'm not formally trained in this, but how do you utilize, I know you spoke on all the modalities, but how do you utilize that, or do you utilize that? And what other kind of modalities do you use to help with shifting thought patterns that would help to facilitate healing in those who have central sensitization?
Chronic pain is a very complex, multifactorial syndrome that, and certainly identifying those risk factors, that central sensitization is really important and kind of necessitates the psychological intervention to kind of work on all these multiple levels. And we know how CBT and ACT, we're addressing thoughts and feelings and behaviors, really do start to shift the brain and change the landscape of the brain. But CBT, as you mentioned, cognitive behavioral therapy, and ACT, acceptance and commitment therapy, are both widely researched and generally considered a standard of care in pain psychology. I do use both those modalities. CBT focuses on the relationship between what we think, feel, and do, which are all key components in mediating that brain body response. Very strong data behind it that healthier thoughts, feelings, and actions do produce better outcomes in pain treatment. The good thing about this is that our thoughts and actions are mostly under our conscious control, and therefore a place we can affect change now. It's been compared to a verbal judo, so it allows us to avoid thought traps or inaccurate thoughts that may perpetuate negative feelings and alarm states. For instance, we talk about catastrophic or black and white thinking, focusing on the past, or fortune telling, all of these thought habits keeping us in these thought loops that really perpetuate the alarm state in the nervous system. And sometimes we don't even have to decide if these thoughts are good, bad, false, or true, but are they helpful? Do they move us forward? Are they action oriented, or do they keep us stuck? ACT, on the other hand, a little bit different. It's about accepting and learning to live with pain, but limiting the control it exerts over life. So if you imagine it, you're at a beach and you're swimming in the ocean, trying to shove a beach ball under the waves, and how much energy that would take, versus if you were to just let the ball float onto the surface of the water instead. And this is a common ACT metaphor, right? To demonstrate how much effort is exerted in suppressing negative sensations of pain, right? So ACT is about learning to ride the tide and commit to oneself to live in the service of values despite pain, helping folks shift from identifying as sick to someone who could still enjoy a satisfying life. A patient recently said to me, what an awakening and an eye-opening experience to realize that life may not look exactly as he'd imagined, but it could still be meaningful and purposeful. And that was very profound. I'm doing this for 30 years, so there are obviously elements of so many modalities that have just made their way into my work. So it's very much curated to the individual, but some other very compelling treatments and patients respond really well to are biofeedback, sometimes called meditation of the West. And this allows us to observe the state of the nervous system in real time using electrodes that measure things like heart rate, respiration, muscle tension, and so on. While there's good empirical data on its efficacy for certain conditions like headache, migraine, hypertension, digestion, I find it particularly helpful in building confidence and skills and helping patients to learn to trust their body to relax. Often that trust is broken, and being able to rely upon the body. Safe and sound protocol. This has been seeing tremendous results with this. This was created by Stephen Porges, and it's based on his work in polyvagal theory, which is all about the science of feeling safe. SSP uses filtered music to stimulate the vagus nerve, which signals safety in the nervous system. This is shifting the nervous system from sympathetic to parasympathetic, fight or flight, to rest and digest. It connects the mind and the body all the way from the brain to the intestines. So it's a very effective treatment, especially when there are other comorbidities around pain. What I love about it is that it speaks directly to the nervous system without much input from the patient. So patients often being so depleted. By the time they get to me, they feel very comforted and calmed by this program. We also mentioned I'm an acupuncturist, and I do use this, to treat the body level, local dysfunction, injury, pain, and many other issues. But I also use it psychotherapeutically. And this is always very curious to people what this looks like. But we're treating emotional energies in the channels. I will be with the patient for the full time that they're on the table, guiding them through breathing, mindfulness, visualization, hypnosis. I use something called open focus sometimes, which is a means of moving our attention away from pain to safer spaces, process experiences as they come up in real time without the inner critic. And this may be sensations, memories, thoughts, and this is especially effective where there's emotional trauma and the superficial layers start to peel away. Patients have often described very deep experiences with this and have even compared it to being on the continuum with psychedelic treatments. It's a very profound experience. And acupuncture is also very powerful in stimulating the body's natural opioid system, right? And endorphins. So I use tapping with patients very often. A lot of people have heard of this. This is particularly helpful for anyone who has difficulty meditating or when the feelings and pain are too big. This is very fast acting. So it's very accessible compared to other methods of meditation that require more time and practice. And again, just stressing that there are all these other comorbidities and just casualties that really need to be a part of the work. Whether there's often sleep problems, right? As we know, depression, grief, loss, anxiety, guilt, shame. I mean, just the whole spectrum, and any underlying emotional issues. Pain psychology has to pay particular attention to very practical work that may involve logs, patient logs, tracking their symptoms, having those back pocket tools, as we mentioned, developing emergency relief plans that include these meditations, breathing, maybe essential oils, bath salts, soothing teas, affirmations. We use pain transforming imagery, so from sharp to dull or hot to cool. The language we use around pain is as you know, very significant. I have some patients who really love to assemble a pain kit or a self-care basket to have on their bedside table. They forget what works for them. When you're in a pain crisis, it's really hard to remember to do these things for yourself. So it's very multifaceted, right? Very complex, and so many strategies that we will sometimes use that are too many to mention, but those are kind of highlights.
I think it's incredible, specifically what you just said about the use of acupuncture, and then in real time, as the emotions come up, processing them there, that you're able to facilitate that with your patients. It's incredible. We sometimes have similar experiences in our office for patients when we're doing craniosacral therapy or visceral manipulation, where they have an emotional response, and that's normal. And we give them the disclaimer beforehand that may likely happen. And I encourage them to do whatever they need to do for processing, follow up with their psychologist, but to have you there as that's happening, I mean, that's really incredible. I want to touch on neuroplasticity. What that means, neuroplasticity, our brain and our nervous system is neuroplastic. So we are able to influence the central nervous system for the better and to help to reduce the symptoms. And that's really what we're aiming to do with all of these things that we're talking about. What happens with patients and individuals who are having a persistent pain state, sometimes we already mentioned central sensitization. And so what can happen sometimes in our brain has a map or a sensory homunculus. I presented this in the pain science event. Sometimes if a specific part or region of your body, you're experiencing the persistent pain, that region will become larger or hyperalgesic or hypersensitive. And when we're using all the modalities that Dr. Barbiere just mentioned, and then even in physical therapy, that we do in the office, we're helping to promote positive shifts so that we're influencing the neuroplasticity to reduce that painful experience. And then I wanted to transition now into trauma and emotional trauma. I know that's a whole nother podcast we could have, but I just want to mention it because with an emotional trauma, you absolutely can be experiencing physical pain. I want to say when we're talking about the biopsychosocial model, it can be a psychological, sociological, traumatic experience that causes physical pain manifestation, and that pain is real, as Dr. Barbiere mentioned in the beginning. How do you work with patients who are presenting with psychosomatic pain or pain as a result of emotional traumas?
I'm glad you're mentioning this. This is a very common scenario that we see in the office. There is a very strong association between chronic pain and emotional trauma. Right? Trauma and pain bodies both tend to become fear bodies and need to be restored to safety in similar ways. And I'll just briefly mention ACEs, right, which are adverse childhood experiences, which are basically significant childhood stressors and are known to contribute to higher rates of all sorts of diseases as well as pain conditions. The higher the ACE score, more likely there's some predisposition to physical and emotional problems later in life. We know that pain and trauma seem to share similar pathways, both contributing to structural changes in the brain, orienting us to detect danger. If the system is already fired up, one may be more prone to sensitization and persisting pain patterns. And chronic pain itself comes along with a lot of trauma, medical trauma, right? A host of other life altering stressors. I always approach chronic pain through a trauma lens. We never know what a patient has been through when they get to us. So we don't even know the full extent of it. In fact, I find sometimes that memories of trauma don't come up until the pain starts to wane and there's a healing crisis. And then the floodgates open and things come up. There's certainly the school of thought. Many people have heard of John Sarno. In John Sarno's lineage, when emotional trauma is too painful, the brain actually chooses physical pain over emotional pain. So, and they treat at that level by really accessing those deeper emotional issues that may be driving pain conditions. I do work with a lot of trauma, more, like I said, more than I'm even aware of, understanding that it's not something to forcefully dig up or purge. It's a process that unfolds in its own time with the right help, ultimately transforming the relationship to the trauma and how it manifests in our body. And so using very trauma specific therapies for this. We may use mindfulness, journaling, again, both bottom up, top down modalities. Sometimes patients can say, I process my trauma, I'm over it. But as we know, it still very much exists on the body level, where they may still be habitually guarding and protecting and contracting, and it can become a barrier to recovery. Traumatic experiences may never fully reach a level of consciousness, and that's okay too. Recovery can still happen. When things happen in childhood, we may not always have developed the language to put it into words, but there can still be healing around it. So it's very delicate and requires a safe space and the right support, or it can be re-traumatizing. So always making sure that a person's getting professional help around it.
Thank you for that. I know that it's a whole nother topic that we could go into much deeper. I wanted to move into movement practices as a physical therapist. We are doing manual therapy. Specifically, I mentioned different techniques for those who have persistent chronic pain, but we're also doing therapeutic exercise and movement. And at our office, we use a lot of mindfulness-based techniques, but we heavily use Pilates in a more rehab modality function for our patients. And I wanted to know, what other movement modalities do you recommend for patients who have fear related to movement?
Well, I love that you're integrating mindfulness into this work and that you're very cognizant of the emotional material that comes up around it, and that you're sensitive to that and detecting it and finding a way to process that with them, whether in real time or referring out. I think that's so important and not common. So I commend you for attending to that. So regarding movement, the habitual fear and avoidance always kicks in again, right? Leading to inactivity, guarding, bracing, deconditioning, and so on, which can thwart recovery. I know you can certainly take us deeper into some of these things, but from a psychological perspective, it's not uncommon for patients to develop kinesiophobia or a fear of movement when movement becomes associated with pain. So we know that sometimes even imagining movement or watching someone else move can induce pain and inflammation. We have to use in psychology some form of systematic desensitization or gradual exposure to build pain and movement tolerance. And this could mean starting with visualizing movement and working our way up the movement ladder, pairing movement with safety and relaxation. This is actually a cornerstone of pain reprocessing therapy. And of course, I'll emphasize that this is only movements that are deemed safe for the patient by you professionals, right? And patients can start to learn that hurt does not always equal harm. That's kind of our mantra when I work with patients, right? They can continue to feel safe even with some discomfort. And what's interesting is we find that there is a tendency to want to muscle through, push through movement. But without the foundation of safety, it doesn't work. If you don't have the infrastructure of understanding about the pain that leads to fundamental shifts in beliefs and feelings around it, that's when people hurt themselves, right? That is not constructive, progressive working through of like the fear response. I also, besides some of these behavioral techniques and visualization, I use a lot of Qigong that comes from my Eastern background, which is a very gentle desensitization. It's modified, of course, for whatever patient can do. It's a moving meditation and incorporates breath and movement in very gentle, slow ways that improve agility and ability to be in the body in safer ways. And it just engages the whole body and kind of breaking through some stagnation that develops some stuckness in the body.
Wonderful. I am definitely going to borrow the hurt does not equal harm. I like that. Why would you say that some people might be resistant to seeking care from a pain psychologist? And then, more importantly, for myself and my colleagues in physical therapy, what do you recommend for practitioners like myself who recommend and explain and educate about pain science and refer for pain psychology, but patients might not reach out? What can you say to that?
Basically, I'd say assess and address the underlying resistance. It's really evaluating like what are the barriers to following through? Is there something that doesn't feel safe? Is there some potential danger in excavating some deeper issues, right? Maybe emotional fear and avoidance. So eliciting from patients what they imagine pain psychology to be, any specific concerns, misconceptions, information and reassurance. Limited resources, right? I mean, time, money, energy. What is the benefit cost ratio, right? They really have to buy into the benefits of doing this work. Maybe helping them envision how it would fit into their life and their schedule, maybe time management work, right? Knowing they can do this remotely can make a big difference. They can always start with just a phone call. I consult with patients on the phone. We can talk about pain psychology and what our work might entail once I get a little bit more information about them. And more often than not, I find that once they make that first connection, they're on board and they'll take that next step. So just making that call. Patients really grasping that treatment in a vacuum is not enough, the physical treatment in a vacuum. Ideally, letting it be an open part of the conversation. So it's tricky when psychology is not routinely integrated and prescribed, then people feel singled out. So normalizing it, It's also most effective when all the members of the patient's team are on the same page. If the message is just divided, patients will opt out, right? Tapping into pure family support can offer that extra push. Maybe asking patients to attend a pain psychology workshop or group or even an online forum can feel like less of a commitment, right? And less threatening. At the end of the day, just really putting ourselves in their shoes and what would make me take that next step, being positive, really reinforcing, emphasizing all that the patient is doing right and the gains they've made, and how pain psychology can really be a part of getting them over the finish line. Athletes use it all the time, and there is no shame in it.
Thank you for that. So, how do you see treatment for persistent pain advancing in the next 5 to 10 years? Where do you see it going?
Thought a lot about this. I can list a lot of things that I wish for. Of course, medical advances in the treatment of chronic pain, but from a sociological and psychological perspective, I have a whole agenda, right? Like, I want to expand public awareness, like what you're doing here, campaigns, increase social discourse around chronic pain. As a society, we can all benefit from heightened sensitivity around what it's like to live with chronic pain and illness. It's a real thing. I hope for more widespread education and support for patients and caregivers. That is grossly missing, these kinds of support for the caregivers, loved ones, patients. It's just not accessible enough. I hope mental health treatment becomes more routine and accessible and the stigma squashed. I have to say Manhattan Pain Medicine is really a model program in their interdisciplinary approach to pain, which is very hard to find in most pain treatment centers. I would like insurance companies and medical providers to recognize psychology as an important component, and also training medical providers, non-pain specialized medical providers in chronic pain, because many non-pain docs don't understand enough about chronic pain. And I hope there's more widespread information so patients aren't marginalized. And I started this work over 30 years ago at an HIV mental health clinic in Brooklyn in an inner city. And this was the biopsychosocial crisis we were in the middle of. And I have to say, unfortunately, as a society, I don't think we've come far enough. We're still quick to shun and shame and make people feel like outcasts, and it's very alienating. So I really hope for there to be more public awareness.
I hope for that as well, and it'll be interesting to see where things go in time. But I wanted to say, do you have any final words of encouragement to anyone who's listening as we close up this conversation today?
We talk about safety buckets and threat buckets in treatment a lot. Patients can really wrap their heads around it. So really think about replenishing those safety buckets, right? Reducing the threat in their lives as much as possible. Maintaining hope, hanging in there. You're not alone. If relief comes with your 15th or 25th doctor's appointment, I think, people really want to be around to witness that. So it takes time and persistence and patience, and creating a life worth living now. This made me think about the way we sometimes end our pain group. Patients really like this. There's a Buddhist loving kindness prayer that we say at the end. We take some calming breaths and we repeat to ourselves, may I be safe, may I be healthy, may I be free of suffering, may I lie with grace and ease. I think it's an important wish for ourselves.
Beautiful. Absolutely.
For this journey. Yes. Thank you
so much, Dr. Barbiere. Thank you for your time and for having this conversation with me. It's so important. And I want to thank all of our listeners. Thank you for tuning in. Stay tuned next time for another informative talk on the Know and Do Better podcast. Thank you.